So, I have to tell today about what is gastroesophageal reflux disease and what are the sign symptom, what is the pathophysiology, as well as what are the treatment, how to investigate, as well as what are the do's and don'ts about gastroesophageal reflux disease and whether operation or surgery is going to help. As you know, gastroesophageal reflux disease, as the name mentions, the gastro means stomach, esophagus means esophageal is esophagus, reflux means reflux of gastric content into esophagus causing disease. It can be of two forms. One is endoscopy positive, other one is endoscopy negative called NERD or non-erosive reflux disease, where endoscopy is normal but patient can have findings. So basically the lower esophageal sphincter is a sphincter that constricts the esophagus lower end and prevents the migration of food into the esophagus. If it is hypotensive, that means if the pressure is low, most of the stomach content can go up and cause reflux symptoms. The reflux could be acid reflux, reflux could be bile reflux, starting from the biliary content can go into the stomach and can go into the esophagus. Most of this type patients complain of bitter taste in the mouth, but those who have got acid reflux can complain of acidic taste or heartburn or regurgitation of food. These are the symptoms of hyperacidity and GERD. So basically, as I have already mentioned, the gastroesophageal reflux disease is a disease of the lower esophageal sphincter. There could be anatomical abnormality or there could be functional abnormality. Anatomical abnormality could be like hiatus hernia. Functional abnormality may be because of the lower esophageal sphincter pressure to be low. And the role of hiatus hernia, as you know, hiatus hernia can be there associated without any positive findings. And sometimes hiatus hernia are associated with ulcers, and those are usually not very symptomatic. Once they are symptomatic, very symptomatic and they are very big, that could get strangulated, and those are the patients who require surgical treatment. Most of the time the treatment of GERD is a medical treatment and surgical treatment is very limited and just to restrict to very few patients who are refractory to usual line of treatment and those who need very long-term treatment. And one other thing that I have to tell about this investigations. What are the factors that contribute? For example, certain food and beverages. For example, if you take alcohol, coffee, smoking and peppermint, cola drinks, orange and citrus fruits, and certain medications can aggravate the GERD symptoms. So that is the reason why you have to avoid certain cola drinks, peppermint, chocolate, coffee and these type of things. The symptoms could be like heartburn. The most predominant symptom is heartburn. Many patients complain that this is as indigestion. Indigestion is a very bad thing because all the things like fullness of abdomen, abdominal discomfort, gaseousness, early satiety, means fullness of meal, discomfort with meal, this could be dyspepsia or indigestion. So the common symptoms like heartburn is present in majority. There could be chest pain that can mimic almost like a cardiac chest pain. But the differentiation, how to differentiate between these two, in cardiac chest pain are usually aggravated with exercise, but esophageal chest pain are associated with food ingestion. There may not be any relation to exercise. And if you take nitroglycerin or GTN, the cardiac chest pain are usually relieved very fast and the pain usually goes to the jaw, lower jaw and can be radiated to the left arm. This is how you differentiate between cardiac chest pain, non-cardiac chest pain. Sometimes it may so happen that patient can get admitted to coronary care unit with the chest pain and all the cardiac investigations may be negative. You have to do endoscopy in them to see whether they have got reflux disease. And those who have no positive finding, you can do a acid stimulation test called Bernstein test to find out whether they have got NERD. This endoscopy is negative in them. So how we investigate? Most commonly we ask patient initially as a empirical treatment with proton pump inhibitor, and some who have got very severe symptoms, we ask them for upper GI endoscopy. Besides endoscopy, we can do a barium skygram to look for any hiatus hernia. You can do certain impedance manometry, pH manometry, and to see the esophageal manometer sphincter pressure. These are the investigation how you can assess whether the patient will be benefited from surgery or not. Those patients who are refractory to the proton pump inhibitor and those are endoscopy negative, these are the patients which usually are subjected to this type of investigations. And whether they require surgery or not, very few patients require surgery, and this is a surgery called Heller's. This is a Nissen fundoplication. This is the treatment where you make a stitch around the hiatus. As you know, hiatus hernia is by definition is a hernia in the hiatus. What is the hiatus? Hiatus means the esophagus passes into the via diaphragm to the stomach. So the continuity of esophagus and stomach is through a hiatus. If there is a gastric migration into the esophagus, upper part of the chest, in the gastric migration is into the chest, not upper part, into the chest is called hiatus hernia. Means anything from part of the stomach is called a sliding hiatus hernia. There is a hernia which goes, the stomach goes into the hiatus into the lower chest. So these are the what are the complications? One is most important is one should look for what are the complications. If there is a esophagitis, then if a long-term esophagitis, there could severe esophagitis can give rise to esophageal stricture. That can give rise to Barrett's metaplasia. That can be, if there is a very bad esophagus, that can present as a GI bleed like hematemesis or melena. If there is a Barrett's metaplasia, there is a likely chance that the Barrett's metaplasia means the epithelium lining is changed to columnar epithelium. Normally this is stratified squamous, and that can give rise to Barrett's metaplasia, can give rise to adenocarcinoma of stomach. So you have to look for alarming features in patients who have got reflux esophagitis. If patient has got dysphagia, means swallowing problem. If patient has got a GI bleed like hematemesis or melena. If patient has got weight loss in patient with the GRD, you have to investigate these patients and treat with proton pump inhibitors. Normally you give with a proton pump inhibitor early morning, and if there is an associated regurgitation of food, you along with a PPI, you give a prokinetic so that the gastric content doesn't come up. So along with one thing I should mention that in pregnancy there is a high likelihood of this GRD. Similarly, patients who are obese, because of increased intra-abdominal pressure, there is a high likelihood of obesity. So treatment includes not only medicines, you have to take lifestyle modifications, you have to avoid certain foods, you have to ask them to raise the head end of the bed, not by putting one pillow, by putting one brick height at the head end of the bed. And you have to ask them not to take water immediately after food, take at least 2 to 3 hours after food, or just give a gap after food, not to take water with the food, and at least they should go to bed at least 3 hours after the dinner. They should have early dinner and go to bed later. So these are the certain precautions you have to take. You have to avoid cola drinks, you have to avoid chocolates, coffee, and stimulants of the lower esophageal sphincter. So these are all how you go ahead with GERD. So lifestyle modification, treatment and management of maintenance treatment is very important in this type of patients.